So this video is continuation of our last video on afterload and the treatment of hypertension. So two types of drug used in the treatment of hypertension are the venodilators and arterial dilators. So what is the difference between the drugs which dilate the arteries and the drug which dilates the veins? Those which dilate the arteries, they decrease the afterload, and those which dilate the venous system, they decrease the preload. So how the drugs that dilates the arterial system, they work? They reduce the peripheral vascular resistance, thereby decrease the afterload, and they decrease the blood pressure. They also decrease the left ventricular end systolic pressure and left ventricular workload. And how the drugs that dilate the venous system, they work. They decrease the venous return, decrease the preload, decrease end diastolic volume, and decrease the workload. The group of drug that dilates the arterial system is hydralazine, minoxidil, diazoxide, and nitroprusside. Hydralazine causes direct relaxation of arterial smooth muscles. So how does it do? How does it dilates the smooth muscles in the artery? Number one, it hyperpolarizes by opening the potassium channel. Number two, it causes a decrease in calcium release from sarcoplasmic reticulum. And the calcium, once it's released, it activates the myosin light chain kinase, which induces contraction. And number three, this stimulates the formation of nitric oxide by the vascular endothelium, leading to cyclic GMP mediated vasodilatation. And why a reflex tachycardia caused by hydralazine? It's due to the activation of the baroreceptor reflex. So the side effects are SLE-like syndrome, tolerance, ischemic heart disease, reflex tachycardia. So what is the role of beta blockers? Beta blockers, when used in combination with hydralazine, controls reflex tachycardia caused by the hydralazine. Also alpha-methyl dopa and clonidine, which are centrally acting alpha-2 agonists. Next drug in this group is minoxidil. The side effects are hypertrichosis and pericardial effusion, and also reflex tachycardia and coronary artery disease. Diazoxide is given IV only. It belongs to the group of thiazide drugs. In fact, it increases the sodium retention, and also it causes hyperglycemia, hyperuricemia, gout, and congestive cardiac failure. The next drug in this group is sodium nitroprusside. It releases the nitric oxide, activates coronary cyclase or cyclic GMP, then activates protein kinase, then it activates the myosin light chains involved in a muscle contraction. So once the myosin light chain is inactivated, it causes vasodilatation and decrease in blood pressure. The nitric oxide, what does it dilate? It dilates both arterioles and venules. Dilatation of arterioles decreases the peripheral resistance, that decreases the afterload. And dilatation of the venules decreases the venous resistance, and that decreases the preload. So nitroprusside decreases both afterload and preload, but it dilates arterioles more than the venules, so it decreases afterload more than the preload. So how does nitroprusside causes cyanide toxicity? Cyanide ion halts the cellular respiration That is, it causes histotoxic hypoxia. How does it causes histotoxic hypoxia, or how does it inhibit the cellular respiration? It inhibits the enzyme cytochrome oxidase in the mitochondria. Does it cause cyanosis? It does not cause cyanosis directly. Instead, it causes cherry red skin color. So why there is cherry red skin color in cyanide toxicity? Due to increased venous hemoglobin oxygen saturation. What are the clinical features of cyanide toxicities? Cardiac arrest, respiratory arrest, seizures, and confusion. And what is the treatment of cyanide toxicity? Cyanide antidote kit contains a small inhaled dose of amyl nitrite, followed by IV sodium nitrite, followed by IV sodium thiosulfate, that converts hemoglobin to methemoglobin to thiocyanate, which is a non-toxic substance. What is the treatment of methemoglobinemia? The treatment for methemoglobinemia is methylene blue. What is the role of hydroxycobalamin? It is a newly approved drug for cyanide toxicity. What are the drugs used for severe and malignant hypertension? The IV vasodilators used for severe and malignant hypertension are two types, quick acting and the delayed onset acting. The one with the quick acting, their action starts in 1 to 2 minutes, and that of the delayed action, that it starts in 10 to 20 minutes. The quick acting IV vasodilators are sodium nitroprusside, nitroglycerin, diazoxide, esmolol, and pheneldopan. The delayed onset IV vasodilators are hydralazine, labetalol, and nicardipine. The other group of vasodilator is ACE inhibitors, angiotensin converting enzyme inhibitors. How do they act? The ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2. So what is the difference between angiotensin 1 and angiotensin 2? Angiotensin 1 is an inactive substance, whereas angiotensin 2 is the most potent vasoconstrictor known. Number 2, ACE inhibitors inhibit aldosterone production. Number 3, they also prevent the degradation of bradykinin. So bradykinin is a vasodilator substance, so increasing the vasodilator substance. And last is it alters the prostaglandin production, especially with captopril. The ACE inhibitors are especially useful in renal parenchymal disease hypertension and in diabetes mellitus. What are the side effects of ACE inhibitors? A dry cough, angioedema, urticaria, low blood pressure, and hyperkalemia. In congestive cardiac system, what system is accelerated? It is the renin angiotensin aldosterone system, which is accelerated in CCF, so use with caution in patient with CCF. What is the caution to be taken with use with diuretics? Stop diuretics 2 to 3 days before the start of ACE inhibitors to avoid low blood pressure. Which ACE inhibitor is excreted in the bile? It is fosinapril, which is excreted in the bile. What are the contraindications of ACE inhibitors? Angioedema. So if somebody has angioedema intolerant to ACE inhibitors, what drug you use? That is angiotensin receptor blockers are used in them. The next contraindication is bilateral renal artery stenosis. Use may cause acute renal failure. Third contraindication is pregnancy. Hyperkalemia of more than 5 millimoles per liter. Heart failure with hypotension is also an indication for the contraindication for ACE inhibitor. And if the serum creatinine is more than 3 milligram per deciliter, ACE inhibitors are also contraindicated. So these are the conditions where the ACE inhibitors are contraindicated. Angioedema, bilateral renal artery stenosis, pregnancy, hyperkalemia more than 5, heart failure with hypotension, and serum creatinine more than 3 milligram per deciliter. How do you use the ACE inhibitor with spironolactone, and why should we use with caution? So it is used with caution with spironolactone. Why? Because spironolactone also causes hyperkalemia, and ACE inhibitors also cause hyperkalemia. The next group of drug, vasodilator, are angiotensin receptor blocker. What do? They are competitive inhibitor of angiotensin 2 receptor sites. Competitive inhibitor at receptor. They are used in patients if they are intolerant to ACE inhibitors. They also cause hyperkalemia, but they do not cause cough or angioedema. Contraindications to angiotensin receptor blockers: bilateral renal artery stenosis that causes ARF, pregnancy, hyperkalemia, heart failure with hypotension. So same as that of ACE inhibitors. The next group is the aldosterone antagonists used in hypertension. The group include, what are the drugs in that? Spironolactone, triamterene, amiloride, and eplerenone. What do? They decrease the mortality, decrease sudden death, and decrease the pump failure. They should be used with caution with ACE inhibitors and angiotensin receptor blockers. So what drug is used if the patient is intolerant to both ACE inhibitors and angiotensin receptor blockers? If the patient is intolerant to both these drugs, he is given hydralazine and oral nitrates. The next group of vasodilators is calcium channel blockers. How do they act? They are the direct arterial vasodilators and block the calcium channels. Verapamil and diltiazem are their examples mainly. All calcium channel blockers are negative inotropic and negative chronotropic, especially verapamil and diltiazem. They decrease the AV conduction. Another side effect of calcium blockers are second and third degree heart block. They cause hyperkalemia and hypotension. Why short-acting calcium blockers are not used as a first line of therapy for hypertension? Because short-acting calcium blocker may cause ischemic heart disease more than the other drugs. That is why long-acting calcium channel blockers are more first-line treatment for hypertension. So what are the drugs that cause hyperkalemia? ACE inhibitors, receptor blockers, calcium blockers, and aldosterone antagonist, spironolactone, triamterene, amiloride. The receptor blocker drugs. The receptors are of three types: alpha, beta, and dopamine D. What are different types of alpha receptors? They are alpha 1 and alpha 2. What is the difference between alpha 1 and alpha 2? Alpha 1 receptors are mainly present postsynaptically, whereas alpha 2 are present presynaptically. They increase IP3 production and increase and produce Cyclic AMP is a second messenger, where alpha 2 blockers, they inhibit the cyclic AMP. Alpha 1 increase the production of norepinephrine. Alpha 2 inhibit the norepinephrine release. So what are the effects of alpha 1 receptor stimulation? Alpha 1, as it produces norepinephrine, causes vasoconstriction, muscle contraction, sphincter relaxation, ejaculation, and pupillary dilatation. How it causes pupillary dilatation? It supplies to the dilator pupillae muscle. So how about the constrictor pupillae? Which nerve supply constrictor pupillae? It is the postganglionic parasympathetic fibers of the serially ganglion of the third cranial nerve, the oculomotor nerve, that supplies the constrictor pupillae. Which drug is alpha 1 selective antagonist? Prazosin. Alpha 2 agonist is clonidine and methyl dopa. So what are different types of alpha blockers? The alpha blocker may be a non-selective alpha blocker or alpha 1 blocker, or the one used for hypertension are alpha 2 agonist. Because the function of stimulation of alpha 2 receptor is vasodilatation and muscular relaxation. So alpha 1 blocker non-selective are phenoxybenzamine, phentolamine, tolazolene, and trazocine. Their side effects are postural hypotension, stuffy nose, and miosis because they block the sympathetic supply. The selective alpha 1 antagonists are prazosin, first dose produce postural hypotension, terazosin, dexazosin, and trimazocin. These drugs are used in hypertension, anxiety, post-traumatic stress disorders, and in benign prostatic hyperplasia. The alpha blockers are used with beta blockers and with diuretics. So what is the difference between the non-selective alpha blockers and alpha 1 antagonists? Non-selective alpha blockers, they also block the alpha 2 receptors. And when alpha 2 receptors are blocked, they counter the action of the drug on alpha 1 receptors, which is vasodilatation. Blocking of alpha 1 produces vasodilatation and muscle relaxation. So that effect is counteracted by the stimulation of alpha 2 receptors. The alpha 1 blockers dilate both arteries and veins because both vessels are innervated by sympathetic adrenergic nerve fibers, so they lead to postural hypotension. However, vasodilatation is more pronounced in the arterial resistance vessel. Okay, after the alpha 1 receptor blocker, we go to alpha 2 agonist, not antagonist, because it is the alpha 2 agonist that will reduce the blood pressure. They are centrally acting alpha 2 agonists. They act, where do they act? They act in the on the vasomotor center in the medulla. Clonidine, alpha methyl dopa, and guanfacine are the examples of alpha 2 agonist. So what the activation of the alpha 2 receptor actually produces? The activation decreases the sympathetic outflow, as we just did it here, that alpha 2 inhibit the release, inhibit cyclic AMP and inhibit the release of norepinephrine. So the alpha 2 agonist will decrease the sympathetic outflow. They decrease the heart rate, decrease the contractility, decrease the vascular resistance leading to vasodilatation and decrease in blood pressure. So alpha 2 agonists are used in hypertension to reduce the blood pressure, and alpha 1 antagonists are reduced in hypertension to reduce the blood pressure. So these two receptors are exactly opposite in action to each other. So amongst these centrally acting alpha 2 agonists, alpha methyl dopa, how does it work? Alpha methyl dopa is first converted to alpha methyl norepinephrine, which then acts in the medulla to decrease the sympathetic outflow and leading to the decrease in hypertension. So what are the side effects of alpha methyl dopa? Decrease in heart rate, decreased blood pressure, impotency, impaired ejaculation, positive cum tax, and gynecomastia. Sudden discontinuation of clonidine, which is a centrally acting alpha 2 agonist. It causes rebound hypertension from sympathetic activity. What's the example of alpha 2 antagonist or alpha 2 blockers? Yohimbine is the alpha 2 blockers. Which drug act on both alpha and beta receptors and block them, or alpha beta blockers? Carvedilol and labetalol are alpha and beta blockers, so their hypotensive effect is more pronounced because they block the beta 1 and beta 2 receptors also. The beta receptor. What type of beta receptors are beta 1, beta 2 and beta 3? Which type of receptor mainly present in the heart? It is the beta 1 receptor which is mainly present in the heart, and it is called cardioselective. It is the other organ where it is present is kidneys and liver also. So what are the effects of beta 1 stimulation? Beta 1 receptors are G protein coupled receptors. They increase the cyclic AMP and stimulate protein kinase A enzyme. And that opens, what does it do? It opens the L type of calcium channels from sarcoplasmic reticulum. And calcium is required for muscle contraction. And that stimulates the light chain myosin to contract. The beta 1 are positive stimulation is positive inotropic and positive chronotropic. How do they increase the blood sugar? The beta 1 receptor stimulation causes glycogenolysis in the liver, and it also causes glucagon release from the pancreas, which is hyperglycemic. The next effect of beta 1 is the renin release from JG cells. Beta 1 blockade. So if you block the beta 1 and the macula densa in kidney, so what is the effect of that? It inhibits the renin release because the function of beta 1 receptor is renin release. So if it's blocked, the renin is not released. That decreases the aldosterone production. It causes hyponatremia and hyperkalemia. So the beta 1 blockade causes hyperkalemia. The beta 2 receptor stimulation, what does it cause? It causes peripheral blood vessel and muscular dilatation. It dilates the muscles of bronchi and muscles of GIT and GUT. So the effects of beta 1 and beta 2 are exactly opposite. The beta 2 mainly present in the peripheral blood vessels and muscles, of course, and the beta 1, their stimulation causes So how does it act? Beta 2 stimulation causes cyclic AMP that inhibits the, the light chain myosin kinase. Light chain myosin kinase inhibition leads to dilatation. So which beta blocker is excreted unchanged in urine? Nadolol is excreted unchanged in the urine. What are the functions of beta 2 agonist? The beta 2 agonist causes dilatation of the bronchial passage, vasodilatation in the muscles and liver, relaxation of uterine muscle, and release of insulin. So what is the mechanism of action of beta 2 receptors? Beta 2 receptors are G protein coupled receptor which increase cyclic AMP that decreases or inhibits the light chain myosin light chain kinase, and that causes this is required for the contraction. So when this is inactivated, light chain kinase that causes muscle relaxation. So the mechanism of action of beta 2 receptor may be like this: decrease in intracellular calcium, because calcium is released from sarcoplasmic reticulum for activation, increase in potassium conductance, decrease myosin light chain kinase activity, and this leads to the muscle relaxation and bronchodilation. Which drugs are both alpha and beta blockers? Labetalol and carvedilol are both alpha and beta blockers. So in short, the beta 1 and alpha 1 are similar in action, both cause vasoconstriction and muscle contraction, whereas beta 2 and alpha 2 both cause vasodilatation and muscle relaxation. So what is the effect of beta 1 and beta 2 receptor stimulation on the blood sugar? The beta 1 stimulation causes glycogenolysis and increases the release of glucagon from pancreas. So beta 1 stimulation causes hyperglycemia, increases the blood sugar, whereas beta 2 stimulation causes insulin release, so it will cause hypoglycemia. The diuretics. What is the site of action of thiazide diuretics? They decrease the sodium absorption in distal convoluted tubule and the ascending limb also. They cause metabolic alkalosis by increasing the hydrogen ion secretion in the tubule. What is the effect of hypokalemia on digitalis toxicity? Hypokalemia increases the digitalis toxicity because they both compete for the same site. So in the absence of potassium, digitalis occupies the site and causes toxicity. So thiazides may be added to, may be combined with potassium sparing diuretics, spironolactone and triamcinolone, and they may also be combined with digitalis also. The other actions of thiazides are hyperglycemia and hyperuricemia. Hyperuricemia may lead to hyperosmolar coma. Which electrolyte thiazides increase? Thyroid cause hypercalcemia. So hypercalcemia is beneficial because and it increases the osteoblastic activity in the bones, increases the bone density, and this may be beneficial. So thiazide may be used in patients, in hypertensive patients who are osteoporotic because of the old age. Which other diuretic has the similar site of action as thiazides? Metolazone, which is a non-thiazide, it has the site of action similar to thiazides. The loop diuretic. The most potent loop diuretics are bumetanide and furosemide. Bumetanide and furosemide. How potent bumetanide is from furosemide? Bumetanide is 40 times more potent than furosemide. What type of a drug is furosemide? Furosemide is a sulfur drug, whereas thiazide is also sulfur, but ethacryonic acid is not a sulfur drug, but it also acts on loop diuretics. Both furosemide and ethacryonic acids are loop diuretics. Where do they act? They act in the thick ascending segment of the loop of Henle. What is the effect on renal blood vessel? Furosemide causes renal vasodilatation, increases the renal blood flow, increases the urine formation. That is why it is used in renal failure. It also causes, like thiazide, metabolic alkalosis. But it decreases all these electrolytes: sodium, potassium, calcium and magnesium. This is the difference from thiazide, which increases the calcium. They cause hyperglycemia. The next, what is the effect of a loop diuretic of furosemide on the pulmonary pressure? It decreases the pulmonary capillary wedge pressure before, and it's very quick, and before it causes diuresis. And this action is done by pulmonary vasodilatation and venodilatation. So that is why this drug is very effective in pulmonary edema and in heart failure, acute heart failure or pulmonary edema. Which loop diuretic causes deafness? Ethacryonic acid causes deafness. Furosemide also causes tinnitus and deafness. Aldosterone antagonists we already discussed: decrease mortality, decrease sudden death, decrease pump failure, and the site of action is collecting duct and distal convoluted tubules. So what is the mechanism of action of spironolactone and where does it act? Spironolactone is a competitive inhibitor of aldosterone, and it acts in the distal convoluted tubule and blocks the sodium reabsorption, causing sodium diuresis. And number 2, it inhibits the potassium secretion in the distal convoluted tubule. So this is how it causes hyperkalemia or preserves the potassium, and this is how it causes hyponatremia. So what are the contraindications to spironolactone? Hyperkalemia, hyponatremia and renal failure. Why spironolactone causes gynecomastia? Because it's a steroid drug, so it causes steroid-like effects. The Venodilators. Nitrates are the main Venodilators. They produce nitric oxide in the vascular cells, and that produces relaxation of vascular smooth muscles. So what will they do? They decrease preload or afterload because they dilate the veins, so they decrease the preload, but they also cause coronary dilatation, coronary arterial dilatation also. What are the other drugs that cause venodilatation? Sodium nitroprusside, morphine, and the loop diuretics, as we just discussed about the furosemide.